Hello and welcome back to our EMG case cracking. We're up to case number 7. I went very basic in my image creation for this video. I went with a digital art depiction of a hand with the thumb, highlighting some nerves, some electrode placements and waveform visuals there, and tried to get this little subtle professional medical illustration style. I think it worked out okay. Anyway, let's do this. Case number 7, 52-year-old female, cat bite. This does happen. This patient waited a few days, unfortunately, eventually went to the ED, and they immediately put them on IV antibiotics. And this is all too common of a situation, and we're actually going to talk about that a little bit later. Continue to have issues, dorsal radial wrist pain, and some feelings of altered sensation and numbness in the thumb and the first dorsal web space area. So, of course, someone said, okay, let's order an EMG, but also an ultrasound. We'll talk about that as well. So we veered a little bit from our typical format where we present the nerve conduction stuff first and then build the differential. This had just a very interesting history that we started with that in terms of the cat bite. First thing, dorsal web space, if we're thinking of differentials, of course, radial sensory neuropathy. Anyone with thumb symptoms, we got to think about carpal tunnel, especially if it's the right hand, their dominant hand. Could also think about de Quervain veins, right? Radial styloid tenosynovitis, first compartment. I don't know if anyone's heard about this. If you're kind of a student or a learner or kind of new, you might not have heard of intersection syndrome. Some of you that work with hand clinics hear this all the time. There's two versions. There's a proximal, which is the first compartment rubbing and causing friction and inflammation over the second. That would be APL and EPB in the first, rubbing over ECRL and ECRB in the second. But there's also a distal, which would be EPL over the ECRL and ECRB. And there's a little quick kind of mnemonic to remember the dorsal compartments of the wrist. Well, not really a mnemonic, but an easy way to remember. And the last one would be maybe the infection is still smoldering and has not fully been treated. Here's some nice pictures, probably should have shown that earlier, of the intersection syndrome, proximal and distal. So here we go, nerve conduction studies, and if you review this chart here, no real prolonged latency of median sensory across the carpal tunnel. It may be borderline, but with temperature correction, that would be considered normal. Radial sensory on the right, on their affected side, actually better amplitude than on the left, 40 versus 20, so that doesn't quite fit with a radial sensory neuropathy. So we go to radial at the index finger here, sorry, not index, at the thumb. When we compare right and left here, the latency is 2.3 versus 2.1, no major difference, and amplitude essentially the same. We do like combined sensory index testing for carpal tunnel syndrome. In this case, there was a mild difference, 3.9 versus 3.4, 2.8 to 2.3, 0.5 and 0.5 is 1.0, and that is the positive combined sensory index, or Robinson index, for mild CTS. Now, so far, this case is not that interesting, but don't worry, there's more to it. When we take out the ultrasound here, incidentally, we have bifid median nerves, just two images there, no increase in cross-sectional area of them, but this is why we like ultrasound, because we pick up some interesting things sometimes. Now, they were worried about persistent infection quite a bit, to the point that they decided to get an MRI. And why did they not get other values like labs and ESR, CRP, and whatnot? Well, they did, but for the purpose of this case in orthopedics, PM&R, EMG, we're going to focus on the imaging. So let's see if I can, there it goes. Start here. Radial side of the wrist is right over here, and there's a lot of white going along there and a lot of cobblestoning of the skin. And that is a sign of cellulitis, kind of an MRI sign of that. Can't really see the tendons too well. Here's another image here, if it's going to let, there it goes. On this side, a lot of white, a lot of increased T2 signal on the lateral side, and that cobblestoning appearance suggesting some cellulitis and maybe infectious tenosynovitis. Here's another view, axial view right here, and well, kind of hard to see, but more just that cobblestoning appearance. Don't really see too much else here. When they were taking more sequences specifically for tendons and looking at the tenosynovitis, they got, well, a mess here. You cannot identify much. There is very little diagnostic value here. So, unfortunately, all radiology could say is possibly severe tendinosis and tearing, but of all that motion and reverberation, so to speak, artifact, they couldn't really tell if her first dorsal compartment was intact or not. And then, of course, the findings of cellulitis. This is why they sent her for ultrasound. So I went a little bit out of order there, showing you some of the initial median nerve findings just to clump that with the carpal tunnel. But now we get to her first dorsal compartment. So this is more proximally, and there are the compartment tendons really bunched together. You cannot really see. Not too much tenosynovitis, maybe a slight black ring around there, but not too bad. Moving distally, it starts to widen, and then we start to see specific pieces and divisions. The tendons are starting to, well, break in half here. And if you continue distally, now we got a bunch of pieces of tendon. So this looks like a mess. Here's some examples, just pull off the internet, what a quote unquote intact set of tendons with just tenosynovitis, black anechoic rings around them, APL and EPB in the first dorsal compartment. But tendinosis and tearings, where you get this heterogeneous, much thicker APL in this case, not EPB, um, and some anechoic clefts in there suggesting some tearing. So heterogeneous thickened tendon with anechoic clefts are the ultrasound signs of tendon tear. So how bad is our case of tendon tearing? Well, it's not. And that's why this is somewhat interesting. If you've never come across this, the first time a student picks up on this, it's pretty fascinating. There are multiple tendon slips of the APL tendon in some cases. In this one, there are 3 of them. In this one, there's like 6 or 7. It's pretty impressive. And they can really vary in number, and you can easily get fooled if you don't realize this natural, so to speak, arborization of the APL. It just happens in a lot of people. Not everybody, but enough that you got to be aware of it. If you're going to do a first dorsal compartment injection and you don't hit all of the tendon sheaths and kind of pepper the cortisone all around, you're going to get a partial response. And if you don't do an ultrasound before to see if there's arborization or multiple tendon slips and you just fire away, this is why there's such a variable degree of improvement with the Quervain's cortisone injections. Interestingly, though, there's a lighter side to this. You can use one of these if their patient does have multiple tendon slips for a tendon transfer surgery, and you're not going to get any loss of function, which is kind of cool. Now, that was really the main teaching point for this case. We have a companion case coming up in the next slide here. But as I like to finish up and review here, things I could have done better, of course, do the other thumb. That's the wonderful thing about ultrasound. You can't do another MRI the other hand. Insurance, that's just a tough thing with insurance. That's a no-go. But ultrasound, you just bring it on over. I did not do that in this situation. I was a little bit in a rush in this case, but I got the area done, and I took my time making sure those were tendon slips and then just moved on. But it would give you more confidence in terms of calling this thickening or calling it tear or calling it absence of tendinosis. I did scan the intersections. I didn't capture an image of that, and I should have done that because you could further your differential and knock some items off that or put some items in for proximal or distal intersection syndrome. So teaching point here, if you've never seen this before, watch out when you're scanning the APL and have some caution on calling a tendon tear if you're not aware of tendon slips. Now, companion case, another cat bite. These two happened actually within about a week and a half of each other coming into the EMG clinic, which is kind of interesting. This one is a case of multiple cat bites over the past actually 2 years, I believe, is starting in 2023, and as of this video, 2025. The patient went through several rounds of antibiotics to clear up some infection, and at one point they said, "Uh-oh, maybe there is infectious tenosynovitis, and well, maybe we should look at this a little closer." They were seen by our hand clinic. They discussed cortisone injection. They were wondering, gee, if there's just residual tenosynovitis, it'll be great. But if you got an infection, this is going to blow up. We all know if you put cortisone in an area of infection, that infection can progress out of control, and it would be quite a mess. The reason why they came to EMG clinic is they were also having numbness. And if you just listen to this case here, both hands with driving. Nocturnal wrist braces help. If you forget to wear them, the next morning she wakes up with numbness. So that we kind of know where this case is going. And yes, she's seen a chiropractor for neck pain, so this was an easy call to order EMG to check on some things. All right, so what do we have here? Yeah, not that exciting. Maybe a little bit of conduction slowing across the carpal tunnel, borderline prolonged latency, but with temperature, you could call that normal. If you jumped the thumbs here, maybe a little bit. I'd call that more on the right. Likely mild positive right CTS, but really the left, that didn't really look that exciting to me. Motor pretty much normal, so we're not worried about that. So basically, in this case, we have mild right, maybe left median neuropathy at the wrist, pretty mild stuff. But yeah, we're talking about the cat bites here. We're not going to end with just a boring case of carpal tunnel. We want to know about these cat bites. So here we go. MRI. This is the patient. Axial view dorsal compartments of the wrist. This is a mirror image. Sorry if it wasn't really flipped. Otherwise, all the wording would flip here. But first compartment here, second compartment here, third, fourth, fifth, and sixth. And we are concerned about the second and the third here. If you're looking at this MRI, there's a pretty good amount of fluid signal right here already, and maybe in third, actually third and fourth really, but first really looks pretty quiet in this case. So the cat bite was likely along this area. That's the beginnings of Lister's tubercle right there, which is represented there. Here is a labeled drawing of all the compartments here, and easy way to remember this: longest, brevis, longest, brevis, longest. So it's a nice way to go right on through to remember the order as you're scanning on MRI and on ultrasound. So first compartment, second, and then third. This is the MRI, and where the cursor is here, that is the beginnings of the third dorsal compartment with some T2 fluid signal already proximally. This is the beginning of the marker dot where the patient had their pain. And if I go through this here, there we go, there's the marker dot again. And as we're going through, you see the third, and there's the second. You can see the third is going over the second, over ECRL and ECRB there, and then it jumps into place right there. That's the third. There's Lister's tubercle right there. So we have the second compartment inflamed, third also inflamed. These both have quite a bit of T2 signal right there and there. As we continue, actually, let me back up here. So here's the first there, second there with inflammation, third there also inflammation, extensor indicis and extensor digitorum in the fourth, the abductor digiti minimi on the fifth, and then right in the end there, ECU on the sixth. So, and I'll bring this back over here. This is what we are worried about here and here, and that is a good amount of inflammation in that second compartment. But the third, as it goes right over it, you wonder, gee, is this a case of intersection syndrome of third over second? They tried the injection, and then they sent them here for EMG and a follow-up ultrasound instead of a follow-up MRI. Median nerve is borderline large. It's above 10, 11.4. Some people say 12 and above would be abnormal. There is a volar wrist ganglion. It's a long axis view, and that's the scaphoid there. So if I go back, you could probably capture it on the MRI if you just scroll backwards. There's a little bit of T2 signal at the bottom of the image on the volar aspect of the wrist. When we move to ultrasound, there's the second compartment, really not anything major in terms of inflammation, so the cortisone injection worked. And there's the third, here's Lister's tubercle right there in the third compartment, really not much inflammation to speak of, so things got a heck of a lot better after injection. So the summary and the teaching for this case: beware of infectious tenosynovitis. It can be quite a problem. Regular old tenosynovitis is not a big deal, but if it gets infected and that infection can spread along that tenosynovial sheath, you can get what's called the Dr. Canavel or Canavel or Keneval signs here. 4 classic signs that is going to give you that supportive or infectious tenosynovitis, which is a big problem. And yes, this is the best mnemonic, right? But it's easy, helps to remember. Just think of those fingers held in flexion, extension pain, that sausage digit. If it happens, that is, you are immediately calling the hand team, putting them on IV antibiotics and getting them immediately there because this is a surgical emergency. You are going to lose tissue is just going to eat away at everything, and you can get osteomyelitis. These are not going to come up on EMG, of course, a case of infectious tenosynovitis, but it's still important to know. And if you do EMG and you work with a hand team, which I do a lot of, it is good to be aware of this. I did not know this when I first started, but cat boys have an incredibly high rate of infection. There are a lot of studies out there that basically say 1 in 3, when you're looking at all the numbers, is going to get infected and even ends up getting hospitalized in a Mayo Clinic study. This stuff is pretty scary. When you compare that to a dog's teeth, which is blunter and actually leaves a larger wound but doesn't penetrate as much, that actually does not get infected as highly as cats. You got that real pinpoint deep penetration and can seed bacteria right in the tendon sheath and then the joint if they bite right down on the joint. And since the mark is much smaller, people often ignore it and think it'll get better, and then it just spreads and spreads and spreads. So watch out for the cat bite.